Hello, everybody. I'd like to say a warm welcome to everybody who connected to us this afternoon. We are hosting an ERA e-seminar on behalf of ERBP, European Renal Best Practice, which is one of the committees of the European Renal Association with the mission to improve the life of people with kidney disease in a sustainable way by communicating knowledge in a format that stimulates its use in clinical practice in Europe. And today we'd like to host an e-seminar on the topic of thrombotic thrombocytopenic purpura, or short TTP. There were recently new guidelines on the diagnosis and treatment of TTP issued by the International Society on Thrombosis and Hemostasis, and ERBP now endorsed those guidelines, and we'd like to discuss these guidelines and the evidence behind those guidelines. So my name is Maria Hanna. I'm from Austria. I'm a nephrologist and a clinical researcher, and I'd like to introduce or ask the panelists, the experts in the area of TTP, to introduce themselves. And I'd like to start, ladies first, with Professor Katrin Eller, please. Would you like to introduce yourself?
So thank you very much, Maria. It's a pleasure to be on board today. My name is Katrin Eller. I'm a nephrologist working in Graz, Austria. And I'd like to continue in alphabetical order. So next, please, Professor Paul Pinkötter, would you like to introduce yourself?
Thank you, Maria. It's my pleasure too to be here today on this panel board, and I thank the organizers for putting this together. I'm also a nephrologist at the University Hospital in Cologne, Germany, and I'm primarily involved with in and outpatient care of our patients.
Thank you. And so next on the alphabetical order would be Professor Paul Koppel, please.
Hello, everybody. Hello, Maria, and thanks for this invitation. I'm delighted to be here today with you all. So I'm a French hematologist, and I'm interested on thrombotic microangiopathies for some years now, and I lead the French Reference Center for the Management of Thrombotic Microangiopathies.
Thank you. And next, please, Dr. Long Zheng from the US.
Thank you, Maria. Yeah, my name is Long Zheng, and so I'm actually at the University of Kansas in the Midwest of the United States. And so I'm a pathology by training. I also attend the transfusion service as well clinically, but my interest really lies on the study pathogenesis of TTP and novel therapeutic of TTP.
Thank you, Professor Zheng. Professor Zheng is also the representative of the ISTH, who has jointly organized and hosting this e-seminar on behalf of those guidelines on TTP. And also, maybe it's good to mention at this point that Professor Paul Koppel was part of the guideline development group, as also Dr. Zheng was for the original guideline issued by ISTH. And all other panel experts, so Professor Paul Pinkötter and Professor Katrin Eller, were a part of the working group to endorse, together also with Professor Paul Koppel, to endorse the ERBP endorsement. Okay, so I think that's it for the introductions. I'm starting to share my slides now. Okay, so that's just a short overview of the program. We will have a few short background information, then a panel discussion, and then of course also there should be enough time for questions from you, from the audience. So please, if you have questions, just drop them in the Q&A function of Zoom so that I can look at them and monitor and ask them to the panel experts. We'd like to start with for a few questions so that we also get to know our audience. And there is going to be a poll by Zoom. This should pop up. For question 1, we'd like to know, where do you currently practice medicine? Southern Europe, Northern Europe, Central Europe, Eastern Europe, or even outside of Europe? Okay, so here we see the results. So 13% of practice in Southern Europe, 16% Northern Europe, 38% Central Europe, 9% from Eastern Europe, and 24% outside of Europe. So welcome everybody around the globe. And I'd like to advance to our second poll question. Since how many years do you practice medicine? 0 to 3 years, 4 to 5 years, 6 to 10 years, or even more than 10 years of experience? Okay, so we have a lot of people with a lot of experience here. The majority practices medicine since more than 10 years. That's 78%, and then 14% 6 to 10 years, 6% 4 to 5 years, and 2% 0 to 3 years. Okay, and the next poll question would be, how many TTP cases do you treat per year? 0 cases, 1 to 3 cases, or more than 3 cases? Okay, so 31% see 1 year, 0 case per year, half of participants 1 to 3 cases, and about 20% more than 3 cases. Okay. Last question, and then it's on us to answer questions. Did you ever use cablatisumab before? Yes or no? Okay, the majority did not use cablatisumab before, 76%. By the way, I also belong in this group, and 24% did use cablatisumab before. Okay, thank you very much for participating in that poll. I think that's also important for the panelists so that they know a little bit more about the audience, since we in the virtual world we don't have much interaction with you. Okay, so let's go to the background slides on TTP and TMA, and I'd like to hand over to Professor Brinkhoetter, who will give those background information together with Professor Katrin Eller.
Yeah, thank you, Maria. So, dear colleagues, we thought it would be a good idea to start with some background information, basically to bring everybody on the same page. Today, in this e-seminar, we will talk about TTP, and I think it's always important to recall that when we talk about TTP and other TMAs, to emphasize that thrombotic microangiopathies do not represent one specific disease entity, but rather a pattern of injury, which is often seen in the clinic. And we can distinguish several entities. So on the one hand, we have the toxin-mediated hemolytic uremic syndrome, very often diagnosed in children, where we have toxin-producing E. coli strains. On the other hand, we know about complement dysregulation and atypical hemolytic uremic syndrome, and of course, TTP, where the metalloprotease ADAMTF13 is. However, we have to always keep in mind that there are associated conditions, secondary TMAs, which may present with similar laboratory findings, low platelets, high LDH, low haptoglobin, schistocytes, and even renal failure or other organ dysfunction when we see or when we treat our patients after organ transplantation, or when we look at certain infections, cytomegalovirus virus, HIV, but also certain drugs or malignancies may induce TMAs. So in the clinical decision-making process, it's very important to make the right diagnosis. And here, of course, it's good to have a good biomarker. When we talk about TTP, we focus on the metalloprotease ADAMTS13 and its activity, which will basically guide our way to make the right diagnosis. On the next slide, you get an idea about our current concept, how ADAMTS13 actually and the metalloprotease works. So in the upper panel, you have the normal homeostasis. On the vessel wall of any vessel in our body, we have von Willebrand factors, and under conditions of stress, the cells produce more, and the metalloprotease ADAMTS13 binds to the endothelial cell and cleaves ultra-large von Willebrand factors, as shown in the upper panel. In TTP, and actually we talk about two different conditions. On the one hand, the Upshaw-Schulman syndrome, where we have mutations, point mutation, single nucleotide exchanges in the ADAMTS13 gene, and because of these mutations, no functional ADAMTS13 activity, or, and this is more often the case, 95% of our patients have autoantibodies directed against the metalloprotease ADAMTS13, leading to a dramatic decrease in its activity. And in the end, we have large von Willebrand multimers, which form thrombi in our small vessels. And this makes clear that literally every organ can be affected. On the next slide, we have another cartoon summarizing these findings. So again, on the left side, the normal condition, ADAMTS13 binds to the endothelial cell and cleaves large multimers of von Willebrand factor. If ADAMTS13 activity is missing because of autoantibodies, we have adhesion and aggregation of platelets binding to the large multimers of von Willebrand factor and occlusion of the vessels. A few years ago, a cameloid nanobody, so a part of an antibody, the heavy chain only antibody was developed. It's called caplacizumab, which specifically binds to the A1 binding domain, interfering with the binding of platelets or thrombocytes to von Willebrand factor. And by doing so, caplacizumab very effectively interferes with the formation of small thrombi. And there were several landmark studies on caplacizumab and on the use of caplacizumab in TTP. And here is one example. It's so the first phase 2 study was the Titan study, published I think in 2016 in the New England Journal. A few years later, the Hercules trial, also published in the New England Journal. And then in 2021, a combined analysis published in Blood Advances, looking at the effects of caplacizumab. And the authors could convincingly show that caplacizumab not only prevents refractoriness, but it also decreases mortality in ATTP. If we pool both studies, we see a significantly reduced time to platelet count normalization and a reduced incidence on the composite endpoint of TTP-related death, exacerbation, or one or more major thromboembolic events during the treatment period. These very well-controlled clinical trials later been further validated and confirmed by large real-world cohorts. There has been a large cohort from my co-panelist, Paul Copper from France. It was a prospective study on the use of caplacizumab. Mary Scully and Tina Dutt from the UK also published more than 100 patients treated with caplacizumab. We collected data in Germany and Austria, pretty much confirming main findings of the Titan and Hercules trial. And I think one very remarkable finding, and this is shown on the next slide, comes from Paul Koppo's study, where he compared, and this is shown here in red, the new treatment paradigm, the combination of first-line caplacizumab together with plasma exchange and early use of rituximab and, of course, glucocorticoids to a historic control, a historic cohort that was not treated with caplacizumab. And we not only see that the patient responded faster than the historic control, but also the early use of rituximab in combination with caplacizumab led to a faster recovery of the ADAMTS13 activity. So all in all, we move forward when we in our treatment protocols, how to treat our patients. And another thing that became clear in these studies, and this is shown on the next slide, is that ADAMTS13 is not only our biomarker to make the right diagnosis, but it also helps us to guide the treatment modalities. So in the German cohort, we looked into the data and how our colleagues performed and guided their treatment modalities. And it turned out that many did not strictly follow the Hercules protocol and rather looked at ADAMTS13 activities to decide when to stop, when to terminate the caplacizumab therapy. And whenever ADAMTS13 activities were above 10%, the outcome was favorable. When it was below 10%, there was a high risk of relapse. And this is very much in line with the published Hercules data. And Maria, if you click 2 more times, it became clear that all relapses occurred within 2 weeks after stopping caplacizumab, and only in those when the ADAMTS13 activity was below 10%. So ADAMTS13 is very important, not only to make the right diagnosis, but also to help us to guide treatment modalities. And of course, this data is, these findings were taken from our retrospective cohort, and future studies will help us to basically further validate this approach. So where do we stand right now? And this is summarized on my last slide. How has the therapy evolved over the years? So I would say that the treatment of acquired and better immune-mediated TTP is now based on 3 major columns. On the one hand, we have plasma exchange, and the idea is to remove the autoantibody and to replace ADAMTS13 enzyme and its activity. The second step is the von Willebrand anti-von Willebrand agent caplacizumab to reduce exacerbation, to limit microthrombi formation, and of course to accelerate platelet recovery. And the third, and this is as important, if not more important, the immunosuppression, which from my point of view, but this is something we should discuss, means the combination of steroids and rituximab upfront. So with this, I turn to you, Katrin.
Thank you very much, Paul, for the nice introduction. So you already heard that we have fundamental changes, not only starting with understanding TTP better, then coming to the right diagnosis, and finally to huge changes in therapy. So that was, I believe, the basis for the starting the process of having new guidelines from the ISTH, and we are very glad that Professor Lang Sang is on board today, who guided those guidelines. And I will now briefly reflect the main issues and also the results we came up to from a European perspective when we endorsed those ISTH guidelines, and also tried to have some more refinements from an European perspective. So just for your daily practice, I believe there are 2 scores that might help you to somehow get a picture how high the probability of your patient is that he or she really has is suffering from TTP. So there's the plasmic score as well as the French score that are outlined here. They can be found in the guidelines as depicted here, and they simply tell you that you just need a few parameters to get a feeling how high the probability of your patient is that he or she suffers from TTP. So you need the platelets, you need the serum creatinine levels, you need hemolysis parameters, and of course you need a bit of anamnesis, whether there has been a previous cancer in the past, whether there has been a history of solid organ transplantation or stem cell transplantation, and you need some parameters more as outlined here. So you can, just by taking points, you can evaluate quite easily how high the probability of your patient for ITTP is. So that is one of the starting points that can be used for your daily practice. And Maria, maybe you can switch. So these are the guidelines from the ISTH that put these scores on the top. And then if you have your patient with a very high probability to have ITTP, then you should immediately start with total plasma exchange as well as the steroid treatment. And we are pretty in favor of and already in line with those comments and with these guidelines. And then there have been 3 different scenarios, depending on how fast you will receive the ADAMTS13 activity from your lab. And we are very much in favor of scenario A from the European perspective. So we are very much in favor to have ADAMTS13 established over the European countries and to have it as fast as possible. So of course, in an optimal way, even within 24 hours, but it should be within 72 hours. And then you have your result, and then you can easily decide what to go next. So for the scenario A, if you have really ADAMTS13 activity below 10%, and we are very much in favor of starting caplacizumab with the data we have so far, and also to add rituximab. Of course, there has been other scenarios with a later time point. So there's also a scenario C from the ISTH guidelines. If you have the ADAMTS13 activity only ready between 72 hours and 70 days, so within a week, or as scenario B outlined on the right path, whether you don't have any ADAMTS13 activity levels available in your country or in your region. So in case you have that within the 7 days, you still can consider starting caplacizumab earlier, and we are in favor of doing so, but we highly urge that to have those testings available throughout your countries as fast as possible. And we also go in line with the ISTH guidelines that if you don't have those measurements available, that you don't consider to add caplacizumab. So from our European perspective, we believe that we should have those measurements available across Europe to shorten the time to TTP diagnosis, and also to really start caplacizumab when you have your diagnosis really established, because nevertheless, caplacizumab has some side effects, such as bleeding episodes. So it's, of course, we are very much in favor of having that ready as quick as possible. We believe, as outlined in the guidelines, that total plasma exchange as well as steroids remain the cornerstones of the acute ITTP treatment. But we also believe that rituximab really improves the time to ADAMTS13 remission, and also it decreases significantly the number of clinical relapses in acute ITTP. We also believe that rituximab is a brilliant preemptive strategy in patients with an ADAMTS13 relapse. So we believe that it is very much important to measure ADAMTS13 activity throughout the patient's history and in the follow-up period. And if there is a relapse, then to preemptively treat them with rituximab again, not to get them into a clinical relapse. And finally, we also are very much in favor to treat the patients with capivasertib. It improved the therapy of TTP impressively. And we also believe that there will be new therapies as well in the future that can be added in the TTP therapy and will add to our current existing therapeutic possibilities. So thank you very much.
Thank you, Professor Brinkhütte and Professor Eller, for this very comprehensive and nice introduction. So now I'd like to start the panel discussion. And my first question goes to Professor Zheng. Can you tell us a little bit about why ISTH engaged in guidelines on TTP, and what were the rationale for ISTH to produce a guideline on that rare disease?
Thank you, Maria. Yes, I'd be glad to talk about that. First of all, I want to thank European Renal Best Practice Group for endorsing the ISTH, the first ISTH TTP guideline. So this is actually a guideline that produced with almost 2 years of work from many experts all over the world, people from France, England, and Germany, and Japan, and United States. And so it's really an international group of experts spending a lot of time on that. So the rationale for ISTH, of course, to produce this kind of a guideline is, of course, the TTP, as you mentioned, or as the poll indicated, many physicians, even hematologists, they don't see TTP very often. So in most cases, 1 to 3 cases per year. And in some other instances, you probably don't see any in 5 to 10 years or so, even during your practice, particularly if you're not a hematologist. So of course, this is putting a lot of stress to the clinician to actually even suspect the patient who had TTP to begin with. So that recently there's a lot of advancement in this particular area that need to be informed. So there's a new treatment such as capivasertib that is available, but not many people actually heard about it and maybe use it. Okay. And also, there's several special situations. For example, now we know there's a clinical remission and the biochemical remission. So when patient had a normal platelet count, but their ADAMTS13 is low, it looks like they're in remission, but they may have some ongoing thrombosis somewhere else that we don't even know. This could cause a long-term consequence to the patient. So what do we do when patient have the normal platelet count, normal LDH, but a low ADAMTS13 during remission? So, and also when patient had the TTP exacerbation or just even low ADAMTS13 during pregnancy, for example. So what we do with those kind of patients? So treating TTP, of course, involve multiple subspecialty, including hematologist, nephrologist, the cardiologist, the obstetrician, nephrologist, intensive care physician. All kinds of people probably will encounter those kind of patients. So there's not a uniform approach for how we actually diagnose and manage those patients. So that's the kind of rationale why ISTH think that we need some kind of uniform approach to these patients. So.
Okay, thank you. Actually, the next question is still on you because we were wondering what the intended scope of the guideline, in particular, what geographical areas you were aiming at, and maybe also in connection with the third question, the rationale why to include a pathway when Adams 13 measurements are not available. So I think there's some reason behind. Of course, there's some reason behind it. Would like to hear about it.
Sure. Definitely, Maria. Thank you for that question. So, of course, the ISTH TTP guideline covers a lot of information, including some of the basic knowledge about the pathophysiology of TTP, and also clinical and laboratory diagnosis pathway, as well as how you actually manage those patients at the different time points, right? And not only during the acute setting, but also during remission, as well as in some special circumstances like a patient during pregnancy. So the ISTH guideline cover a lot of this kind of stuff, okay? And there's they actually have three publications next to each other. Basically, the first one we're dealing with diagnosis. The second one basically dealing with all the treatment recommendation. And then the last one is about all this good practice kind of a statement. So help some of the clinicians to actually utilize all these different modality of treatment. So the guideline, of course, initially the panel believed that the initial guideline should be mainly focused on the area that like in Europe and North American, because those are the country may have the new drug that are available for the use. Then we will expand it into more like a developing or underdeveloped country where these drug may be coming to this area kind of in a delayed fashion, if you will. So I think the guidelines, so mainly probably focus at the moment, more like a European and North American and some other developing countries. So that's what I think the geographic focus for the time being.
Thank you very much. Professor Kopo, during our discussions for the endorsement of the guideline, we intensively discussed how quickly Adams 13 measurements should be available. And can you give us a little bit more insight in why the ISTH guideline covered a 7-day waiting time for Adams 13 activity?
Yes.
Maximum?
Yeah, sure, Maria. This was to emphasize the fact that we need Adams 13 activity now systematically for all patients and as soon as possible to ascertain the diagnosis of TTP, which is suspected clinically and especially based on the clinical scores we talked about, and to justify the specific treatment we offer to these patients. So here there is a, let's say, a compromise between the fact that we need Adams 13 activity as soon as possible for these reasons, and but in the other hand, Adams 13 activity is a highly specialized assay that requires some experience and skill, and this assay may not be so easily available throughout the world and even throughout a country. So in real world, simply only some labs within one country are able to provide Adams 13 activity, let's say on a reasonable duration of time. So to stick to real life, we recommend it strongly to have ADAM13 activity available as soon as possible. So in real world, it is usually within 3 to 5 days. And we stated that this delay should not overhead more than 7 days. But the main idea here is that ADAM13 activity should be available to all patients for whom there is a suspicion of TTP diagnosis, and this assay should be the result of this assay should be available as soon as possible within some days.
Thank you. And Professor Ella, should caplacizumab be started before ADAMS13 activity is available? Now we heard a lot about availability and the time it might take until you have that test result in your hands. But would you or should we start capla before anyways?
So actually, at our center, we are very lucky to have it quite quick, but there might be other centers that might need to wait for 3 days or something like that. So we came to the conclusion, so the working group came to the conclusion that we still would start caplacizumab in such patients earlier as the ADAMTS13 activity levels are available. So if you have a patient with a high suspicion, so that's why those scores might be quite good, then we would still argue to start it even before ADAMTS13 activity is available. But we urge to have it as quick as possible. So in our center, we started afterwards because we have the plus to the benefits to have it very, very fast. But that might not be the case for, of course, for all clinics.
Okay, thank you. And Professor Koppel, what do you think? Shall all patients with an acute episode of ITTP receive caplacizumab? And what's the role of rituximab in this case?
Yes, thanks, Maria, for these important questions. My first answer would be yes. All patients with a diagnosis or strong suspicion of TTP should receive frontline caplacizumab, because caplacizumab clearly showed to prevent unfavorable outcomes in this disease at the acute phase. And these unfavorable outcomes include simply death, refractoriness, and exacerbations of the disease, which means that patients, despite plasma exchange, may experience worsening of the disease despite a well-conducted treatment. And so far, it is not so easy to anticipate which patient will experience such unfavorable outcomes. So some works reported that cardiac involvement, especially a high troponin level, were predictive of death and refractoriness. But so one could imagine to reserve caplacizumab to those severe patients. But today it is not possible to anticipate who will experience an exacerbation of the disease. And exacerbations is a frequent complication in these patients. They typically occur in 35 to 45% of patients, which is a lot. And a very impressive result of in the use of caplacizumab was to nicely prevent such exacerbation. Since studies that evaluated caplacizumab reported less than 6% of exacerbation versus around 40% again without capla. And the last point is that one has to keep in mind that all these complications typically occur during the first days of the management, so very rapidly after the diagnosis. So this is why it's important to provide caplacizumab rapidly to these patients. Indeed, as Catherine said, before ADAMTS13 activity result is available. And as it is not so easy to anticipate who will experience an unfavorable outcome with the historical treatment, all patients should benefit from caplacizumab. And with the systematic use of caplacizumab, all the studies reported that we could nicely decrease the burden of care in this disease, as the use of caplacizumab could reduce by twofold the duration of daily plasma exchange, the volume of plasma, and the duration of hospitalization stay. And now, regarding the role of rituximab, keep in mind that caplacizumab and rituximab address two different aspects of TTP pathophysiology. So caplacizumab, through its anti-adhesive properties, prevents the neo-formation of microthrombi. So it allows a rapid and durable platelet count recovery. But this effect is suspensive, which means that if you stop caplacizumab while the patient still has a depressed ADAMTS13 activity, this exposes patients to a rapid relapse. So there is a need to also address the autoimmune process in this disease with rituximab. So one should definitely see caplacizumab and rituximab as two complementary compounds in the management of TTP.
Thank you. The next question is for Professor Prinkøtter, please. What about, steroids? We heard that they're still a cornerstone in the treatment. And what about dosage and tapering of steroids in TTP?
Thank you, Maria. I think this is a very important question, and I think there is a general consensus on the use of steroids. But as much as we all agree that steroids are a cornerstone of the therapy, it should be initiated upfront very early. There is no consensus on the dosage. In many of us use at least 1 milligram per kilogram prednisone to begin with. But others may also go up to 250, 500, or even 1 gram. So at our institution, we tend to give 250 milligrams for 3 days in the very severe cases. In milder affected, we go for the 1 milligram per kilogram with a maximum of 80 milligrams per day. And I think it's very important to look into the published literature when we talk about tapering of steroids. We learned a lot from the ANCA vasculitis field and rheumatology, where less sometimes is more. And actually the Hercules trial limited the use of steroids for 30 days, if I remember correctly. So at our institution, we tend to taper the glucocorticoids, the steroids, within 30 days. However, if we see signs of a persistent autoimmune activity, meaning prolonged positivity of autoantibodies and low ADAMTS13 activity, we tend to prolong the treatment at a low dose, so meaning 5 milligrams of prednisone and, of course, rituximab.
And also the next question for you, Paul, Professor Prinkøtter, Paul, because we have 2 Pauls in the round. How should we monitor the treatment response, and when should we actually stop plasma exchange and caplacizumab?
Thank you again. I think here we have a paradigm change. So in the past, we used to continue plasma exchange until the thrombocytes have normalized, meaning levels above 150,000. And then at many centers, usually 1 or 2 more sessions were administered before we stopped the plasma exchange. Now I think it's safe to stop way earlier. And again, there is no consensus on when to stop. At our center, we tend to stop once we see that the patient is on a road to recovery, when we see platelets rising, and if we have stable platelets, continuing rising platelets above 50,000, we tend to stop plasma exchange. So way earlier than we used to in the past. But we do continue them on caplacizumab, and we do use ADAMTS13 as biomarker to monitor the treatment duration. So our patients on caplacizumab, we see on a weekly or at least every other week basis, and then we always monitor ADAMTS13 activity. And once the ADAMTS13 activity rises above 10–20%, we stop administering caplacizumab. So we do not wait for the ADAMTS13 to rise to levels above 40 or 50%. Based on Paul Coppo's data and our own data, I think it's fair to stop it once they are above 10 or 20%.
Okay, thank you very much. Paul Coppo, please, again. When do you think genetic workup is necessary in patients who have TTP?
Yes, this is necessary when you consider that the patient may have a congenital form of TTP. And it's indeed important to distinguish the congenital form from the autoimmune form of TTP, because the management of the acute phase and the follow-up are completely different. And so one should think about a congenital form of TTP in any patient with features of thrombotic microangiopathy associated with a severe ADAMTS13 deficiency and no associated antibodies against ADAMTS13. And moreover, those patients typically have a persistent severe ADAMTS13 deficiency. So in these patients with a persistent severe ADAMTS13 deficiency and no repeatedly detectable antibodies against ADAMTS13, so mutations in the alleles of ADAMTS13 gene should be searched for to identify a congenital form of TTP. And keep in mind one point, which is that congenital TTP should be suggested in any kind of thrombotic microangiopathy in children and in TTP during pregnancy, because it was shown that during pregnancy, TTP women may have a congenital form of the disease in up to 50% of cases. So in other words, the congenital form of TTP is very prevalent during pregnancy. The other point is that it's not so rare to observe to observe that patients with autoimmune TTP may not have detectable antibodies at the acute phase, and this occurs in 20% of cases. So 20% of patients with autoimmune TTP may not have detectable antibodies against ADAMTS13, but typically in those patients, ADAMTS13 activity improves after the acute phase. And in this case, there's no need to search for ADAMTS13 mutations, of course. So this means that not all patients with a severe ADAMTS13 deficiency and no detectable antibodies should have a search of genetic mutations. It's only in patients with a persistent severe ADAMTS13 deficiency.
Thank you very much. The last question of the panel discussion before we head to a few questions we have in the Q&A is for Katrin, please. How would you recommend that we should manage patients with ITP ITTP who present with a persistent autoimmune reactivity. So those are the patients who have high autoantibodies and low ADAMS13 activity and who are refractory to steroids and rituximab. How would you treat those particular patients?
Thank you very much, Maria. I think, and I believe this is a very difficult question to answer, and everyone will make it differently, probably. So those patients are rare, but they are there. So we also have one patient in our cohort that was very, very refractory to immunosuppression. So I believe we should be careful whether we have antibodies against rituximab. That might be one possibility why they do not respond to rituximab. You have the possibility, of course, of there have been reports using cyclophosphamide. There have been reports using bortezomib. So different forms how to stop antibody production. So these therapies can be used as alternatives. I also believe that the new anti-CD20 antibodies like obinutuzumab or other anti-CD20 antibodies might also be a possibility for those patients to really respond, because we have quite nice data in other diseases such as membranous nephropathy by using those antibodies for patients that do not respond to rituximab. So they have a better binding capacity, obviously, to CD20, and also have an increased, induce an increased cytotoxicity of T cells, so that the antibodies, let's say, to say it easy, to go away quicker, and that the B cells are depleted in a better way. So that all might be possibilities, but the patients are rare. But be aware, those patients often have a lot of relapses, and you need to critically follow those patients in very short intervals.
Thank you very much. So now we're going to head over to the questions in the Q&A. Thank you for those who submitted questions. Maybe one question to start with is about how to dose plasma exchange. Who would like to take on that question, and what would you recommend in how to dose plasma exchange?
Yeah, I can take this question because I do plasma exchange all the time.
Yes, please.
I need a transfusion service. So in US, we actually do 1 to 1.5 kind of plasma volume. In most cases, we start out with 1.5 for 3 days, and then later on we change it to 1 volume. So, and then continue until platelet count rise to about 150. So.
Thank you. The next question was if there is any role of plasma exchange or rituximab in sepsis-induced TTP, as some studies show there might be benefit from such treatments. Does anybody have?
I maybe can comment on this. I mean, the idea to treat sepsis with plasma exchange, or to support the antibiotic and hemodynamic management by administering plasma exchange, is an ongoing debate. And I think until we have convincing data from clinical study really showing that septic patients benefit from plasma exchange, I would be very hesitant to recommend the use of plasma exchange in these patients. But I think there is a role in TTP, there is a role in good pasture syndrome, and but maybe in some severe forms of systemic lupus erythematosus and antiphospholipid syndrome and so on, But these are very few cases. It's very limited where we really have data supporting the use of plasma exchange. But I would not go as far and say that plasma exchange should be considered as an adjunct treatment in sepsis.
The next question is about the ADAMS 13 or the test exam that you ask for. Is it ADAMS 13 activity or autoantibody titer, or I guess probably a combination of both? So what are the tests that you have to ask for in patients with suspected TTP?
I can take this one, Maria.
Thank you.
So since I also run pathology laboratory medicine, we also do the ADAM-TS13 test here at KU as well. So what we actually ask a clinician to order is the ADAM-TS13 activity assay, which is the most important one. And when the activity is low, so usually we say if less than 30%, you might want to consider looking for antibody. So the antibody could either be done by the titer, which is that you dilute the plasma and look for, at which dilution they still have inhibitory activity to the 50% of normal human plasma. So that's a titer, but the titer usually are pretty low. So in patients with TTP, usually like a 1 to 8 is not very high. Unlike a hemophilia, you can have a several hundred, titer. So so titer can be less sensitive, okay, because a lot of patients will have a negative inhibitor assay. So we actually not using the titer anymore. We use antibody, IgG antibody. So we use the ELISA-based assay to look for antibodies. So if you have a low ADAM-TS13 and you have antibody present, then this patient automatically will classify as an immune-mediated TTP. However, if you have ADAM-TS13 low, but the negative either inhibitor or IgG, this patient does not necessarily automatically call congenital TTP or hereditary TTP, because sometimes the assay may not pick it up. There's still 10% of the patient you may not detect it either by titer or inhibitor assay or by ELISA-based IgG assay. So as Dr. Kopo mentioned, in order to go on to sequence that and call it a congenital TTP, you might have to repeat this test, maybe after treatment or several times. And then also look at for the ADAM-TS13 activity when patient is in remission. If a patient is in remission, the ADAM-TS13 is still low, that could, usually we're not remission if it's still low, right, for congenital TTP. But if it's a patient in remission, the ADAM-TS13 is still low, you might still want to think about is acquired, because, there's always an antibody you're not picking up or cleared by the immune complex. Yeah.
Thank you, Long. Another maybe quite practical question is how one could distinguish paraneoplastic TTP from iTTP when at the time of TMA diagnosis, the neoplasm is not evident, which would be the consequences for treatment?
I can address this question, Maria, if you wish.
Yeah, thank you.
Patients with paraneoplastic TMA typically have typical features, such as first, clinically, they typically present with waste. They typically have a history of oncologic disease, and biologically, they may have DIC, disseminated intravascular coagulation, which is very unusual in TTP, in the typical forms of TTP. And those patients may also have circulating erythroblasts. And this is also unusual in the usual autoimmune TTP. So in the, let's say in the typical forms of paraneoplastic TMA, the diagnosis can be often be made easily at the bed of the patient just by looking at the blood cell count that shows erythroblasts, and on the basis of the abnormalities of the hemostasis results. Yeah, that's it. And lastly, most of those patients, I would say around 80% of those patients with paraneoplastic TMA have normal or detectable Adamson activity. So the enzyme activity may be decreased, but it is more or less rarely below 10% of activity.
Thank you, Paul. Maybe we have a minute or two for one last question from the audience. It's again about the treatment with cablasizumab, and it's about the duration, the recommended duration of treatment, and also especially in regard to Adams 13 activity and blood platelet levels. I know we've touched on this before, but maybe you have a little bit more practical advice in terms of how densely do you monitor, and do you have certain cut off points in your centers where you decide to stop treatment?
So maybe I can take that, Maria, if it's okay.
Thank
So what we are doing is quite in line with what Paul said before. So we are closely monitoring, of course, on a daily basis thrombocyte levels in the early phase. So we're doing that on a daily basis, and if we see a prominent rise, and you see that quite fast when you use cablasizumab. So that goes really within 2 or 3 days. That has been shown in the studies as well. And we see that also in the real life data. So thrombocytes go up pretty fast. And then we stop the total plasma exchange. But of course, we keep the cablasizumab in those patients because it takes longer in your daily clinical practice until ADAMTS 13 levels, of course, activity levels go up to over 10 or 20%. And of course, this is logical because the antibodies stay there. So you need the other line of therapy. So you need rituximab then and can start that quite fast. And we'll then monitor the ADAMTS 13 levels, let's say once or twice a week, and stop cablasizumab. So in our center, we stop it if it is above 20%. Paul said between 10 and 20, I believe that's everything is safe there, but in our center, we stop it at 20%.
Thank you, Katrin. I think we can close the e-seminar now. We've covered the questions from the audience. And I'd like to thank the panel experts for their comprehensive shared expertise. And I'd also like to thank the audience, of course, for connecting with us and also being very active in communicating and interacting with us. So I thank everybody and have a relaxing evening now. Goodbye.
Bye-bye.
Bye-bye.
Thank you.
Bye.
Thank you.
See you
Thank you.
soon.
Thank you.